Hello everyone, my name is Kyori Kim, and I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce Hot of the Press. Twice a month, we'll be hosting Hot of the Press with one of the authors of the latest APS paper and two panelists. It offers you a special opportunity to directly hear from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Thank you, everyone, for joining us. January 1st, Hot of the Press. I'm joined by Dr. Suh from Yonsei University, Severance Hospital, and Dr. DeFazio from Baptist and Anderson at Dr. Florida. And we will start with Dr. Suh's introduction of his paper.
How are you, audience and moderators? First, thanks for having me in this wonderful session. I'm going to present about the perforator-centralizing technique for superthin ALT perforator flaps to minimize the partial necrosis rate. I'm Chul from South Korea. There is no disclosure. The content of this presentation is published on Archives of Plastic Surgery Journal, January 2021. Superthin flap is defined as elevating the ALT flap above the superficial fascia plane. Despite the high demand for thin flap, superficial fascia plane elevation is not so popular because of technical difficulties. Long learning curve required, such as identifying the superficial fascia plane, the ability to dissect and isolate the perforator at the plane, and to control the partial necrosis rate. The partial necrosis rate in a superthin flap is related to angiosomal theory. One of the famous studies from Dr. Michael Sincere addressed that the flap thinning decreased the vascularity of the flap. Some complex type has over 50% decrease of vascular territory. We can agree that thin flap has smaller angiosomal size than normal flap, but in this study, there was a lack of description about the relationship between superficial fascia and horizontal branch. I want to address about a paper that published in 1998 in Paris Journal. It described that the perforators from lateral femoral circumflex has a long course in the deep epiphyseal layer through cadaver study. But there has been lack of the consideration of this anatomy when you make thin flap using the fatting technique in ALT territory. It means that when you put the deep fascia penetrating perforator at the center of the flap, superficial fascia anchoring perforator can be skewed in the flap. To analyze the impact of position of perforator and superthin flap, we use perforator-centralized technique to put perforator on the middle of the flap, and it is performed by rotation or shifting the design of flap after identifying the perforator, even if we can scan CT angio or color duplex preoperatively. In the centralized perforator group, the perforator was anchored to the middle third of the X and Y axis of the flap. In the skewed perforator group, the perforator was anchored outside of the mid-third of the X and Y axis of the flap. Of the 41 patients included, 26 patients had centralized perforator in the flap, and 15 patients had skewed perforator. Mean age, BMI, comorbidity was not significantly different in both groups. There was no statistically significant difference in flap thickness or flap dimension between two groups, and other flap outcome as well. Only partial necrotic proportion to whole flap area is significantly larger in perforator skewed group. 46-year-old man had a traumatic soft tissue defect with plate exposure on his right medial malleolus area. A 15 by 9 cm superthin ALT flap was used to cover the defect. The perforator was encountered more distally, so the design was rotated in order to centralize the perforator. The flap successfully healed without any necrosis at postoperative 6 months. An 80-year-old man showed malignant melanoma on the sole of his left foot. A superthin ALT flap measuring 16 by 5 cm was used to cover the defect. On postoperative day 20, a necrotic area of 17% was noted at the distal part of the flap. The eschar was debrided and the defect was covered with FTSG finally. The eccentric position perforator flap is reliable in classical perforism theory. Direct linking vessel course parallel to the muscle fiber and the major source artery. So even if the perforator is located at the margin of the flap, it would still perfuse the entire flap. But in superthin flap, which is not containing the direct linking vessel, eccentric position of the perforator will not available to perfuse whole flap area. Color duplex scan was routinely done to identify horizontally running branch and perforation per perforator. This is automated for signal at both spots at the separate and network connected. Skin incision was made with a Bovie electrocautery. And the indirect linking vessel was a lighter. Wiring test was done to identify foot fixation. After confirming the superficial fascia, self-retracting hook was applied to expand it. Sometimes you can encounter horizontally running perforator of adjacent territory. It's not a problem. Flap elevation was performed along the superficial fascia plane. Skeletonization of perforator was performed after identifying it.
그렇지.
Confirm the reliability of the perforator with tendon perforating. An elevation of rest of a flap is done. After elevation of rest of all flap beside the perforator, the dissection along the deep edge of a facial layer was started. Originally, running perforator can be confirmed during the dissection. And you can see the direct linking vessel on this right side of the perforator. You can get additional length of the perforator when you dissect the horizontally running branch. The deep facial penetrating point is located at the margin of the original design of the flap. If we design the perforator based on the deep facial penetrating perforator, the flap, the superficial facial anchoring perforator can be skewed along the flap, so we can get a beautiful superthin LT flap for the patient. This study was conducted to minimize partial necrosis along the superthin flap. If perforator accidentally captured this top margin of the flap, the partial necrosis can be increased. Even though additional effort is needed to elevate the superthin ELT flap, such as dissection of the perforator above the deep facial plane and capturing the superficial facial anchored point in the middle of the flap, but this surgical technique improved the safety and reliability of the superthin ALT perforator flaps. Thanks for listening.
So thank you, Dr. Suh, for a great presentation. Dr. Suh is from Yonsei University, and he just presented a perforator-centralizing technique for superthin and ALT perforator flaps, minimizing the partial necrosis rate. And we are today joined by Dr. DeFazio from Baptist MD Anderson at Jackson, Florida. So we'll discuss this paper, and thank you very much for including the video. It's always hard to kind of imagine the technique without the video, and it's really fantastic to watch the video. And I have a question for you. So a lot of us are typically trained to do like the ABC axis for the ALT, like using the lateral patella and the ASIS. So for those who are just finishing the training or young microsurgeons, how do you advise us to kind of try to do this technique? And then what are your tips and pearls for avoiding disaster?
Actually, the ABC point of the original classical perforator flap is for only soft facial or supra-deep facial plane elevation. If the perforator penetrates the deep fascia, is traveling horizontally in random vector. Sometimes it's traveling superiorly, I mean cephalically. So I think the handheld audible Doppler is not enough to localize the perforator. We should confirm the vector of the traveling branch and the superficial fascia anchoring perforator with a color duplex or CT angiography.
Dr. DeFazio, do you have questions?
Yeah, so first of all, I would like to just start by commending Dr. Suh and his colleagues for highlighting a really important but also not so intuitive concept in superthin flap harvest. So just like Dr. Cho was saying, a lot of us in the United States are accustomed to traditional fasciocutaneous flap harvest using the ABC system or marking the ASIS down to the patella and using that 3 centimeter diameter circle to find the most common location of perforators, but that really is only relevant for subfascial ALT flap harvest. So one thing you need to differentiate is that when you're elevating traditional ALT fasciocutaneous flap, there is a variable degree of perforator arborization that's occurring within the deep fascial layer, transverse direction of the vessels, of the linking vessels that occur in that layer. And so you can raise a fasciocutaneous ALT flap with an eccentrically located perforator and still receive pretty good distal perfusion of large skin territories. But when you're doing this at the superficial fascial layer, you're essentially bypassing that network of direct linking vessels. And so perforator location within the flap itself becomes far more relevant. And so I would say that also, in my own experience with doing these superthin flap harvests, I've encountered very similar rates and problems of partial flap necrosis when skin paddles are greater than about 12 to 15 centimeters in length. And so from my standpoint, I've largely abandoned the use of super thin flaps for defects greater than 10 centimeters in size. But I will say that I have also noticed, just as you mentioned in your discussion in your video, that where that perforating vessel enters the deep fascial plane oftentimes does not correlate with where it manifests within the superficial fascial plane. So you can, if you're using the ABC system, you can think that you're designing the flap directly over the perforating vessel, let's say like the B level, but as you dissect through the superficial fascial plane, that perforator may end up being much more proximal, more distal within the flap, creating more of an eccentrically located position. I agree with Dr. Suh that unless you're using duplex ultrasound or some other form of imaging, that it becomes a lot more difficult to do these flaps reliably because you're not really relying on anatomical landmarks as much as you are on the direct visualization of these perforators. So for those of us in the United States who aren't really accustomed to using that technology, performing superficial ALT flap harvest reliably, 100% of the time is a lot more difficult.
And actually, I have one question to Dr. DeFazio. Actually, I ruled out some cases that containing more than one perforator. How do you define the limitation of one perforator's limitation of the size of the superthin flap to support it by the one perforator? Sometimes they require more than two perforator to survive the whole area. So how can you define the limitation of the size based on your experience?
Yeah, I mean, I basically go by exactly what I learned from Dr. Hong when I visited you guys in Korea. Essentially, you're looking for the perforator that's pulsatile, that you can feel like a palpable pulse. I consider that to be more reliable for a single perforator harvest. But in reality, when I try to get fancy on doing things like super thin flaps, I tend to be more conservative and I take more than one perforator. I try to. That does tend to limit the, I guess, how you design your skin paddle, because as you mentioned, you have more of a freestyle harvest where you make a quarter of the length incision, you identify your perforator first, you adjust your positioning later. If you're going to harvest more than one perforator within the flap, I think your perfusion will be better, but I think that it can potentially limit how you design your skin paddle. So there's a little bit of a trade-off. Ultimately what I found is just like limiting these types of flaps to smaller defects, they tend to be very reliable. If you try to cover a large surface area with a super thin flap, whether it's a skip or whether it's an ALT, I mean, you can expect, a fairly significant rate of partial flap necrosis. And even in your centralized group, when you look at your data versus the skewed group, your rates of partial flap necrosis are still on the order of 20%, which is relatively high. So you just have to be selective when choosing these types of flaps. One other thing I will say is, at least in my experience, and I know you mentioned this is in terms of a limitation in your study, but the predominant issue that I have found that contributes to partial flap necrosis has been more venous insufficiency. It looks like if you look at that second case that you showed in your presentation, that may have also been an issue for that flap as well. Have you found that it's more of an inflow problem or an outflow problem?
It was an inflow problem, actually, yeah. There's no bleeding comes out in the pinprick test. So.
Right. And so, in your table too, you show also that about 38% of your perforator-centralized flaps ended up with an end-to-end anastomosis, whereas 53% of your skewed perforator flaps were end-to-end anastomosis. Are you performing these anastomosis perforator to perforator level, or are you using named source vessels as your recipients?
The reason I like to use the superthin ALT flap, not skip flap, because I don't like to do perforator to perforator flap. It makes the flap a little bit unstable. So,
and I agree with that. So then my follow-up question is: do you think that end-to-end anastomosis to a large named recipient vessel provides too much of an unfavorable inflow to outflow mismatch for these thin flaps? Should we be doing end-to-side anastomosis? Should we be considering perforator anastomosis? We're going to go super thin.
Yeah. In my case, usually end-to-end anastomosis is performed in the branch of source vessel, not to main vessel. So the flow is not too high, I think.
I have a follow-up question. So whenever you are kind of assessing your flap, whether it will perfuse all parts of the flap, Do you ever use a SPY to confirm the perfusion of like a venous inflow and outflow, or do you just use like the kind of swipe the edge of the flap and see if it's bleeding? How do you assess your?
Usually, I judge flap status by the clinical
Okay.
diagnosis, but sometimes the clinical diagnosis and flap status not always same. So sometimes I check the color duplex or ICG image to check the flap. So if there is partial necrosis, some partial necrosis can be healed
Right.
after 1 week. So I check the partial necrosis after the 3 weeks later. I always check the final outcome after 3 weeks. So
I was just going to comment on your SPY. I was going to say that if you're going to use fluorescent angiography to evaluate perfusion of the flap, kind of like you mentioned, not only is it important to assess the inflow, but you have to also obtain delayed imaging, 10 minutes or so.
Right.
Make sure that the dye is egressing from the flap.
Otherwise, yeah. And another question I had is, I'm sure you get this question a lot of times. The BMI of your patient is very low and I think it's happens a lot. A lot of papers from Asia, the BMI is really low, and and for those of us in US, I'm sure Dr. DeFazio could chime in on this. For those who are trying to venture out this, and then it's really, I know you mentioned like using the hook to kind of spread it apart, and that's like to find the superficial fascial plane. Yeah. But like for those who might be interested in doing this and then encounter patients who have BMI higher than 25, what will be the best way to kind of try this technique and then minimize the flap failure at the same time?
I think the BMI is also an important issue, but the real thickness of the fat layer is a real problem to elevate the superthin flap. I have experienced that some patients who have over 2 centimeter depth thickness of the thigh area, I can elevate far over the superficial facial plane, making it more thin flap for such a obese patient. So I think the BMI is not a big problem.
One thing that I learned from Professor J.P. Hong when I went out to visit you guys is that he actually said that the flaps are technically easier to elevate in obese patients, which is true because the fascial plane tends to be a lot more distinct, and you almost remove that issue related to obesity with fasciocutaneous flaps is that thick, like parasitic layer of the deep adipose layer gets removed. So you're essentially creating like a level playing field when elevating superficial flaps in obese patients. I think the issue just really relates more to the territory of the flap, but the actual technical flap harvest can be sometimes easier in patients who have thicker, more distinct fat planes.
I think that's the reason that Dr. Takumi Yamamoto keeps saying that the ultra thin flap over the subdermal dissection.
Thank you, Dr. Suh and Dr. DeFazio, for a fantastic discussion. It's really great I think a lot of us at US, are trained to do like a kind of ALT in a reliable way. And I think a lot of us are also recognizing that there's, the superthin is becoming the part of the armamentarium for microsurgery, and it's just not a myth in Asia. And it'd be fantastic to continue to have young surgeons inspired to do this, and that you are part of the inspiration for all. So and thank you very much for all the discussion, and then I think we'll wrap up here. Thank you.
Thank you very much.
Thank you very much for joining this fantastic discussion. Be sure to tune in for other articles we'll be discussing on future Hot of the Press. You can also connect to the Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We are looking forward to meeting you on our APS social media. Let's be social, but distant.